You've probably been told that if a surgeon recommends a procedure, you should do it without question, that modern medicine can fix almost anything: a bad back, a painful knee, a clogged artery. I used to believe that too until I started seeing the same patients return to my office, not healed, but permanently damaged, men and women in their 60s and 70s, who went into the operating room trusting their doctors, expecting relief, and came out with chronic pain that was worse than before, or worse, with cognitive decline that never reversed, with infections that nearly killed them, with a quality of life so poor they wished they'd never agreed to the surgery. And every single time, when I reviewed their charts and talked to their families, the same 3 surgeries kept appearing. My name is Dr. Raymond Cole. I've spent over 20 years treating seniors not as a surgeon, but as the doctor who sees the aftermath when surgery goes wrong. Today, I'm going to tell you about 3 common surgeries that can destroy your independence and your joy. After 60 surgeries you should think twice about, question aggressively, and possibly avoid altogether. This isn't about scaring you away from necessary care. It's about giving you the knowledge to protect yourself when a surgeon's good intentions may not match your best interests. Let me start with something most people don't understand, and it's something that surgeons rarely explain before they schedule your operation. A surgery that is safe and effective for a 40-year-old can be dangerous, even life-threatening, for a 70-year-old. Why? Because your body changes in ways that matter enormously when you go under the knife. It's not just about being older, it's about having less physiological reserve. After 60, your immune system is weaker, so post-operative infections are more common and much harder to treat. A simple urinary tract infection after surgery can turn into sepsis, in a senior sepsis that lands you in the ICU for weeks. Your lungs have less reserve capacity, so pneumonia after anesthesia, what doctors call post-operative pneumonia, is a leading cause of death in older surgical patients. Your heart has less elasticity and your arteries are stiffer, so the stress of surgery and anesthesia can trigger a heart attack even if you've never had heart problems before. Your kidneys filter drugs more slowly, so the anesthesia and pain medications stay in your system longer, leading to confusion, falls, and even kidney failure. And your brain, your precious brain, is much more vulnerable to what we call postoperative delirium. That's a sudden, temporary state of confusion that affects up to 50% of seniors after major surgery. But for many, that confusion never fully lifts. They go into surgery sharp, independent, managing their own checkbook and driving to the grocery store. They come out confused, forgetful, needing help to use the bathroom, unable to remember their grandchildren's names. I remember a patient. Let's call her Eleanor. She was 72, a retired school teacher, sharp as a tack. She played bridge twice a week, managed her own finances, volunteered at her church, and lived alone happily. She had moderate back pain from age-related arthritis, the kind that hurts but doesn't stop you from living. A spine surgeon recommended a spinal fusion. He said it would help her pain. He showed her x-rays and said, "See this disc? It's degenerated. I can fix that." Eleanor trusted him. She didn't know to ask about risks for someone her age. She didn't know about postoperative delirium. The surgery itself went fine, no bleeding, no infection. But after anesthesia, Eleanor never woke up the same. She was confused, agitated, didn't recognize her daughter. She pulled out her 4 lines. She tried to climb out of bed and fell. The hospital called it postoperative delirium and said it would pass in a few days. It didn't. 2 weeks later, Eleanor was still confused. A month later, she was transferred to a skilled nursing facility. 6 months later, Eleanor was in a memory care unit. She couldn't remember her own address. She couldn't play bridge. She couldn't live alone. The surgery hadn't failed. Her back pain was actually better, but her life was destroyed. And no one had warned her that for a 72-year-old, elective spinal fusion carries a significant risk of permanent cognitive decline. I've seen this story repeat itself. With knee replacements, with carotid stents, with many surgeries. That's why I'm making this video. I want to be clear, surgery saves lives. If you have a hip fracture, you need surgery. If you have appendicitis, you need surgery. If you have a blocked coronary artery causing a heart attack, you need surgery. But the 3 surgeries I'm about to discuss are different. They are often elective, meaning you have time to decide, time to ask questions, time to try alternatives, and for seniors, the risk-benefit calculation changes dramatically. Today, we'll cover 3 specific surgeries that I believe seniors should be very, very careful about. Surgery number 1, spinal fusion for chronic back pain that is not caused by a fracture, tumor, or severe nerve compression. Surgery number 2, elective total knee replacement for mild to moderate arthritis that hasn't failed non-surgical treatment. Surgery number 3, carotid artery stenting for asymptomatic carotid stenosis, that is, a clogged neck artery that hasn't yet caused a stroke. For each one, I'll explain the evidence, the real risks for seniors, safer alternatives, and exactly what to ask your surgeon before you sign the consent form. The first surgery that seniors should stop and question is spinal fusion for chronic low back pain that is not caused by a fracture, tumor, or severe nerve compression with progressive weakness. Spinal fusion is a major operation where a surgeon removes an intervertebral disc, the cushion between two bones, and then uses metal screws and rods to permanently lock those vertebrae together. The theory is that by stopping movement between those bones, you stop the source of pain. It sounds logical, but here's the problem for seniors. After 60, the discs above and below the fusion, your adjacent levels are already degenerating. When you fuse one level, you put enormous extra mechanical stress on the neighboring discs. Within 5 years, up to 30% of patients develop what's called adjacent segment disease. Those discs fail under the extra load, causing new, often worse pain that leads to more surgery, a second fusion, then a third. I have seen patients who started with one level fused and ended up with their entire lumbar spine locked into metal hardware. They walk like robots, cannot bend over to tie their shoes, and still have pain. Sometimes the pain is worse. The medical evidence is clear and should give every senior pause. A landmark study published in the New England Journal of Medicine randomly assigned patients with chronic back pain to either spinal fusion or intensive non-surgical treatment, physical therapy, cognitive behavioral therapy, and exercise. After 2 years, there was no significant difference in pain scores or functional ability. Between the two groups, surgery didn't work better than physical therapy, but the surgery group had a much higher rate of complications, infections, blood clots, nerve damage, and hospital readmissions. For seniors, those complications are even more dangerous because recovery takes longer and the immune system is weaker. But there's another risk that's even less discussed outside of geriatric medicine: the cognitive toll of major spine surgery. Spinal fusion typically takes 3 to 6 hours under general anesthesia. For a senior brain, that's a long time without normal blood flow and oxygen. Anesthesia itself triggers inflammation in the brain, and prolonged anesthesia can cause what we call anesthesia-induced neurocognitive disorder. A study from the University of California followed seniors over 65 who underwent major spine surgery. Those patients had a 40% higher risk of developing persistent cognitive impairment within 1 year compared to seniors with similar back pain who received non-surgical treatment. That's 40%. Think about that. For every 10 seniors who get a spinal fusion, 4 will have measurable cognitive decline a year later, not from Alzheimer's, but from the surgery itself, and that decline is often permanent. So what should you do if you have chronic back pain after 60? First, exhaust all non-surgical options before even considering fusion. And I mean really exhaust them. Give each at least 6 to 12 weeks. Good physical therapy, not just a sheet of exercises, but a skilled physical therapist who works with seniors, who teaches you core strengthening, gentle stretching, posture training, and body mechanics. Studies show that 6 weeks of consistent PT can reduce back pain by 50% in most seniors. Second, consider epidural steroid injections. These are outpatient procedures where a doctor injects anti-inflammatory medication around the spinal nerves. They don't fix the disc, but they can provide months of relief with very low risk. Third, try radiofrequency ablation, a procedure where a doctor uses heat to disable the small nerves that are transmitting pain signals. The effect lasts 6 to 12 months, and you can repeat it. Fourth, try cognitive behavioral therapy for pain management. Your brain can learn to interpret pain signals differently. CBT has been shown to reduce pain intensity and improve function without any medication or surgery. Fifth, maintain a healthy weight. Every extra pound puts 4 pounds of pressure on your spine. Losing just 10 pounds can take 40 pounds of pressure off your lower back. I'm not saying spinal fusion is never appropriate. If you have a spinal fracture from osteoporosis, a tumor in your spine, or severe nerve compression causing leg weakness or loss of bladder control, that's an emergency, and fusion may save your ability to walk. But for typical age-related disc degeneration and arthritis, the evidence says no. Walk away from that surgeon and find one who offers non-surgical solutions first. If a surgeon pushes fusion without discussing PT, injections, and CBT, find another surgeon. The second surgery that seniors should think twice about is elective total knee replacement for mild to moderate arthritis. Let me be very Clear for seniors with severe knee arthritis who cannot walk, cannot sleep, cannot perform basic activities of daily living despite 6 months of good non-surgical treatment. Knee replacement can be truly life-changing. I have patients who got their lives back after knee replacement. They can walk their dogs, play with grandchildren, travel again. That is real. But for the majority of seniors with mild to moderate arthritis, the kind that causes pain but not disability, knee replacement is often unnecessary and can lead to worse outcomes than doing nothing. Here's why. A total knee replacement requires cutting the ends of your femur thigh bone and tibia shin bone, removing the remaining cartilage, and installing metal alloy and high-density plastic implants. For a senior, the recovery is brutal. You're in the hospital for 2 to 3 days, then weeks of physical therapy that many seniors cannot tolerate because of pain or frailty. The risk of infection is small but real, about 1-2, but a deep infection in a knee replacement is a disaster. It often means removing the implant, placing a temporary antibiotic spacer, and living without a functional knee for 6 months while you wait for a second surgery. Risk of blood clots, deep vein thrombosis is about 5-10 without proper blood thinners. Those clots can travel to your lungs and kill you. Risk of falls during recovery is high. You're on opioids, you're weak, you're using a walker. A fall can break a hip, and a broken hip after 60 is a life-changing event with high mortality. And here's the research that should make you pause. A major study published in the British Medical Journal followed over 2,000 seniors with moderate knee arthritis. Half received total knee replacement, half received non-surgical treatment, physical therapy, weight loss, pain management, and low-impact exercise like swimming or cycling. After 5 years, the surgery group had slightly better pain scores, about 10 points on a 100-point scale, but they also had double the rate of serious complications. And there was no significant difference in their ability to walk, climb stairs, or perform daily activities like shopping or cooking. Another study found that up to 20% of knee replacement patients are still dissatisfied after surgery. They still have pain, stiffness, or a feeling that the knee is not right or clunky. 4. Seniors, the anesthesia risk alone should make you cautious. Knee replacement takes 1 to 2 hours, but with anesthesia prep and recovery, you're under sedation for 3 hours. That's 3 hours of brain stress. And after surgery, seniors are often given strong opioids for pain, which we know cause confusion, falls, constipation, and long-term dependence. I've seen too many seniors go into the hospital walking with a cane and come out using a walker, permanently weaker, never regaining their previous mobility. So what's the alternative? For mild to moderate knee arthritis, start with physical therapy focused on strengthening the quadriceps and hamstrings. Strong muscles stabilize the knee and absorb shock. Lose weight. Every pound lost takes 4 pounds of pressure off your knee. A 10-pound weight loss reduces knee pain by 50% in many seniors. Try knee braces. Unloader braces shift weight from the painful side of the knee to the other side. Consider hyaluronic acid injections, gel shots which lubricate the joint. The evidence is mixed, but many seniors get 6 months of relief. Use topical NSAIDs like diclofenac gel or capsaicin cream. They work locally without the heart risks of oral NSAIDs, and adjust your activities. Swim, use an elliptical, cycle, or walk on soft surfaces instead of pavement. If you've tried all that for 6 months and still cannot walk to the mailbox or sleep through the night, and only then should you talk to a surgeon and get a second opinion. A surgeon who does 200 knee replacements a year makes a lot of money from each one. They have a financial incentive to say yes. You need someone with no skin in the game to give you honest advice. The third surgery that seniors should be very careful about is carotid artery stenting for asymptomatic carotid stenosis. Let me explain in plain English. The carotid arteries are the 2 big blood vessels on either side of your neck that carry blood to your brain. Sometimes as we age, they get clogged with plaque atherosclerosis. If a plaque ruptures, a small piece can break off and travel to your brain, blocking a small artery and causing a stroke. For decades, the standard treatment for severe carotid blockage was a surgery called carotid endarterectomy. A surgeon opens your neck, removes the plaque, and sews the artery closed. That surgery has its own risks. Stroke, heart attack, nerve damage. Then came a less invasive procedure called carotid stenting, where a tiny metal mesh tube is inserted through a catheter in your groin, threaded up to your neck, and expanded to prop open the artery. Sounds better, right? No neck incision, shorter hospital stay. But for seniors, it's often worse. A major clinical trial called CREST-2 compared carotid stenting plus best medical therapy to best medical therapy alone for patients with asymptomatic carotid stenosis, meaning they had a blockage but had never had a stroke or mini-stroke. The results? Stenting did not reduce the risk of future stroke compared to medication alone, but it did increase the risk of procedural stroke or death during the procedure. For seniors over 70, the risk of stroke from the stenting procedure itself is about 5 to 10%, that's 1 in 10 to 1 in 20, and for what benefit? None. The medication works just as well, so why do surgeons still do it? Because it pays well. Medicare reimburses thousands of dollars for carotid stenting, because patients think they're being proactive, they hear blockage and want it fixed, because surgeons are trained to fix blockages. But the evidence is clear: if you have a carotid blockage but have never had a stroke or TIA transient ischemic attack, you have asymptomatic stenosis. The current guidelines from the American Heart Association and American Stroke Association say that for most seniors, aggressive medical therapy, high-dose statin, antiplatelet medication like aspirin or clopidogrel, blood pressure control, smoking cessation is as good as stenting and much safer. Unless your blockage is 80% or more and you have some high-risk features like irregular plaque or rapid progression, do not let a surgeon talk you into carotid stenting. Take your pills, watch your blood pressure, walk every day, and stop worrying about the number on the ultrasound. That's the real medicine. Now that we've covered the 3 surgeries, let me give you a framework for making any surgery decision after 60, because the problem isn't just these 3 procedures, it's the mindset that surgery is always better than non-surgery. After 60, you have to think differently. You have to weigh quality of life against quantity of life. You have to consider your personal goals. Do you want to live to 95 even if that means spending your last years in a nursing home? Or do you want to preserve your independence, your mind, and your ability to enjoy your hobbies for as long as possible? For most seniors, the answer is the second one, and that means being very selective about surgery. Here is my 6-question framework, and I want you to write this down or save this video to watch again before any surgery. Question 1. What is the absolute risk reduction of this surgery for someone my age with my specific health conditions? Not the relative risk. Surgeons will say this surgery reduces your risk of stroke by 50%, but 50% of what? If your baseline risk is 2%, a 50% reduction brings it to 1%. That's an absolute reduction of just 1%. That's tiny. Question 2. What is the number needed to treat? That means how many people need to have this surgery for one person to benefit. If the number needed to treat is 50, then 49 people had surgery for no benefit but still took all the risks. For spinal fusion, the number needed to treat for meaningful pain relief is often 40 or 50. Question 3. What are the specific risks for someone my age, especially postoperative delirium, heart attack, stroke, infection, and death? Ask for numbers, not general assurances. If the surgeon says you'll be fine, ask again. A good surgeon knows the data. Question 4. What happens if I don't have this surgery? What is the natural history of my condition? Many conditions, mild back pain, moderate knee arthritis, asymptomatic carotid blockage, get better on their own or stay stable for years. You can always have surgery later. You cannot reverse surgery. Question 5. Can I try non-surgical treatment for 3 to 6 months and then reassess? Any elective surgery can wait. Use that time for physical therapy, weight loss, medications, injections. Most of the time, the non-surgical approach works well enough that you no longer want surgery. Question 6. How many of these surgeries do you do per year, and what are your complication rates for patients over 65? A high-volume surgeon who does at least 50 of these per year will have better outcomes, but even then, you need to ask for their specific data. Here is your 4-step action plan. Step 1. If a surgeon recommends one of these 3 surgeries: spinal fusion, elective knee replacement for mild to moderate arthritis, or carotid stenting for asymptomatic stenosis, say this: I want to wait 3 months and try non-surgical treatment. I will come back to reassess. A good surgeon will respect that. A bad surgeon will pressure you. Step 2. Get a second opinion from a non-surgeon, a geriatrician, a physiatrist, rehabilitation doctor, a rheumatologist, or even a good primary care doctor. These doctors have no financial incentive to cut. They will give you honest advice. Step 3. Ask specifically about postoperative delirium. Say to your surgeon, what is my personal risk of cognitive decline after this surgery, and what protocols do you have in place to minimize it? Hospitals that use age-friendly protocols, avoiding certain anesthesia drugs, getting patients out of bed quickly, minimizing opioids, have much lower delirium rates. If your surgeon doesn't know what you're talking about, go to a different hospital. Step 4. Optimize your health before any surgery you truly need. This is called prehabilitation. Spend for 6 weeks before surgery walking daily, eating high-protein meals, stopping smoking, getting diabetes under control, and doing pre-surgery exercises. Prehabilitation cuts complication rates in half and reduces hospital stays by days. It's one of the most powerful things you can do. I became a doctor to help people live better lives, but the hardest conversations I've ever had are not about cancer or heart disease. They are the conversations with families after an elective surgery went wrong, a mother who never woke up the same, a father who went from walking his dog every morning to being bedbound and confused. Those moments taught me that the most important job I have is not just treating disease, it's preventing unnecessary harm. And sometimes preventing harm means saying no to a surgery that a well-meaning surgeon recommends. You have the right to ask questions. You have the right to wait. You have the right to get a second, third, even fourth opinion. This is your body, your brain, your one precious life. Don't let anyone rush you into an operating room. Share this video with a parent, a spouse, or a friend over 60, especially someone who has been told they need back surgery, or knee replacement, or a carotid stent. That share might save them from a lifetime of regret. Hit subscribe to Senior Health Hub for more honest, life-saving information. Next week, we're talking about the 3 medical tests seniors should never take. They cause more harm than good. I'm Dr. Raymond Cole. Stay informed, stay safe, and I'll see you in the next video.